Welcome to our continuing 2021 educational webinar series. I am Catherine Short, Partnership Marketing Manager for First Healthcare Compliance. At First Healthcare Compliance, we help you with a comprehensive compliance management solution tailored to your business. A hospital, hospital network, healthcare practice of any size, billing company, or skilled nursing facility, and we help manage every aspect of a compliance program, and our training library provides hundreds of modules that are easy to assign and track. As part of our complimentary educational webinar series, we bring you experts from around the country to discuss relevant topics in the healthcare industry. We are so pleased to have Sonal Patel, CPMA, CPC, CMC, ICD-10 CM, healthcare coder and compliance consultant at Nexsen Pruet LLC with us today. Sonal serves as the firm's remote expert coding and compliance consultant. She is committed to providing her clients coding and documentation guidance based on government and private payer regulations. Ms. Patel provides detailed, high-level findings reports for practices under ZPIC, UPIC, and RAC audit reviews, as well as risk adjustment audits. She creates custom corrective action plans for both Part A and Part B providers. At the request of many physicians, Sonal conducts baseline audits to assure compliance. Ms. Patel is an avid educator and provides individualized PowerPoint presentations for physician billing and coding education. Sonal's consulting services can be found by searching NP Coding 360 on Nexsen Pruet's About Us webpage. She is also a podcast creator and host of Paint, the Medical Picture podcast series, where Ms. Patel provides valuable content pertinent to industry news as well as coding compliance tips. She comes to Nexsen Pruet LLC with her focused concentrations on the myriad of reimbursement complexities faced by private practice physicians as well as hospital systems. Before Ms. Patel's big move back to the Midwest, she proved instrumental in guiding specialty physicians and surgeons in correct coding and billing practices at one of Texas Medical Center's premier billing companies. During her time at Houston's leading cancer institution, Ms. Patel performed thousands of retrospective audits on professional charges to ensure accuracy of coding and clinical documentation to maintain reimbursement levels. Prior to Ms. Patel's healthcare career, she studied and worked extensively in the field of art history. It was during her times at a world-renowned art institution in Washington, D.C., and her esteemed reputation in modern and contemporary Indian art that Sonal mastered her love of research and writing. Sonal is a true Buckeye and Midwesterner and currently resides in the greater Chicagoland area. Her passion for art continues to this day, and she is never far from an art museum or gallery opening. Before we begin, I would like to mention that at First Healthcare Compliance, we strive to serve as a trusted resource for compliance professionals, and each month we celebrate their hard work and dedication with our Compliance Super Ninja recognition. One Super Ninja our team is turning the spotlight on is Julie Wilkins, Billing and Compliance for Radiation Oncology Associates, PC. Julie's favorite part of working at Radiation Oncology Associates, PC, is that she loves everything about working for Radiation Oncology Associates. The physicians in this practice have never wavered in their commitment to putting the patient first. She has worked with this group both as a therapist and in her current role, and she can't imagine working for a better company. She'll be retiring soon, and she'll miss her coworkers and friends at ROA. Congratulations, Julie Wilkins. Our team at First Healthcare Compliance is honored to have the privilege of working with you. A copy of the slides for today's presentation is available for download on the control panel. Feel free to submit questions into the question box on your control panel during the presentation. We'll address questions at the conclusion of the presentation. Your PAYCOM and PMI CEU certificates will be emailed to you following the broadcast. Your PAYCOM certificate will come directly from PAYCOM, and your PMI certificate will come from our email. There's no need to request either one. Additional CEU opportunities will be available to BC Advantage members following the live broadcast. See their website for details. So, Sonal, a very warm welcome. Thank you for being here.
Amazing, Catherine. Thank you so much for having me. I always enjoy coming on to this amazing platform that you provide to all of us. So thank you. I wanted to just say thanks again for having me, everybody. I hope you find this presentation useful. I've titled it "Have No Fear: Auditing to Benefit Physicians: A Step Towards Proactive Compliance." Now, it's 2021, and this is my biggest thing that I keep shouting out about. I really do believe that proactive auditing internally is going to help our physicians remain compliant. So just a little disclaimer here, obviously, although I work at a law firm, Nexsen Pruet does not accept any responsibility for this educational material. You can read disclaimer on your own. And then, of course, Catherine did a great job talking about myself, all of the services where I can be found on the Nexsen Pruet website at NP Coding 360. And of course, she also talked about my new podcast. This is brand new. I know that Catherine has had her podcast for a long time, but this is only my 14th episode, I believe. So if all of you could join in, subscribe, I would love it. Paint the Medical Picture Podcast. It's on Apple, it's on Spotify, it's everywhere, it's on YouTube. So please tune in. I think there's a lot of great information on health industry news, as well as my compliance tips and tricks. All right, so some of the objectives for this presentation. I want us to be able to walk away understanding and not be afraid that internal auditing is significant. It has significance on protecting our physicians and protecting their practices. I want us to be able to comprehend what internal monitoring is and its importance to the practice. I want us to be able to review the differences in monitoring versus auditing. What are the steps involved in conducting an internal audit? Again, that's when an auditor works for the practice or the physician, not for the payer. I also want us to be able to talk about the different types of audit reports. And most importantly, I want to talk about recognizing the significance of the why in internal auditing. Now, the patient record. I truly believe that the center of the business of medicine, the focal point of all of it, is the patient's medical record. It documents the care, the services, the quality and continuum of care provided to the patient. And moreover, then the practice of abstracting codes, what the certified coder does, both abstracting procedural and diagnostic coding, revolves around the clarity of the patient's chief complaint, their history, their physical examination, and the medical decision making. All of that is in the medical record. Now, the clinical documentation integrity is a whole other webinar presentation I can give, but it's that truth of the patient record that truly supports what the certified medical coder is abstracting. So that clinical documentation has to be really well documented for that coding to be abstracted with accuracy. So never forget the medical record is used as a legal document that captures the quality, the value of care and services rendered for the patient. The why. Now, the regulations, rules that are involved in this space of healthcare, as we all know, is a labyrinth. It's winding, it's complex, and each specialty, each subspecialty also has its own unique sets of standards that must be adhered to. So retaining certified auditors for your practice is beneficial to you for several reasons. They are truly objective. They are there to help you from an outside point of view. They're there to benefit you. They provide an invaluable service to your practice by keeping you compliant while you, of course, do your thing, providing patient care. That's what you are trained for. Let certified auditors do what they're trained for, to protect you. It's an invaluable service. And compliance for the auditor is always what their end goal is. They provide you feedback on where you missed opportunities. They also alert you when you're not coding correctly. If there's some source of coding that needs clarification and rectification. They provide you with honest education on how to improve. They're not there to penalize you, they're on your side. Now, auditor's tools. Now, I am a CPMA, so I have tools and tools and tools for days. So the current coding books are the #1 tools, in my opinion. My books are my go-to. They're my everything. And of course, we have to maintain compliance. We hold that credential dearly. So we also have to maintain compliance and, go ahead and buy current 2021 coding books. They're always current. So like our CPT book by the AMA, I'm looking at mine. I've had mine since October. So even though the codes are just now effective as of January 1st, I had my book in October. Then there's also the ICD PCS book that's used for the hospital procedures in the inpatient setting. That book is also new for 2021. There's also the HCPCS book, also new for 2021, and those were just mailed out right now in January. So those HCPCS codes are all those codes that don't quite make it into CPT, but you'll find all of your Medicare G codes in there, as well as all of your durable medical equipment, prosthetics, and orthotics and supplies for your DME POS codes in HCPCS. And then, of course, we have our ICD-10-CM for 2021. Those codes were effective on October 1st of 2020, and I had my book in September. So it's critical that your auditor remains on top of everything. New codes are published every year. But if there's a post-payment audit that's involved with a practice, an auditor on the payer side will be using past books to support those claims that are billed. So therefore, the auditor on your team should also hold on to those older coding books, because claims are only relevant and valid for that year. So if they had big changes, let's say, for example, in 2017, it's pertinent that a CPMA still has access to those coding books from 2017. Okay, so I've already talked about the fact that the ICD-10-CM codes were effective on October 1st of 2020. January 1st, 2021, the CPT codes just became effective. And then the HCPCS codes for 2021 have been mailed out in January. Now, I always recommend that internal audits should reflect a practice's payer mix. That's key. So you may have lots of Medicare patients, but you do have some patients that come in and present with some commercial plans. So it's important because both types, government and commercial, do have changes every quarter, every year, etc. So it's ideal to make sure that you're still doing things compliantly for both types of payers. So your auditor will also be well aware of where to look for those payer policies. Your auditor should be able to identify your MAC for you. where are you located? So the United States, we should be aware, is comprised of jurisdictions for Part A, Part B, and for DME. So the auditor will ensure that you know who your MAC is. Is it NGS? Is it Novitas? Is it Palmetto? Is it FCSO? Is it CGS, WPS, or Noridian? And an auditor knows that there are multiple jurisdictions for these MACs. An auditor will also know where to locate local coverage determinations, those LCDs for particular CPT codes, or national coverage determinations, NCDs, for Medicare claims as applicable. So there are always changes for LCDs and NCDs as well. The 2021 physician fee schedule was just released and they eliminated 6 NCDs. So an auditor is always on top of things and will keep you in the know. Now, Medicare also has a plethora of manuals, tons of them, from claims processing to benefits to payment integrity that an auditor will also be reviewing to help support you. Now, each state also has specific Medicaid manuals that publish coding and billing guidance as well that may differ from Medicare. Okay, so it's important that an auditor will use those and keep those in their big toolbox. Forget the word belt, that should be box because there's just so much that we need. An internal audit will also be based on commercial payer policy, right? And they also have clinical policy bulletins, etc. Aetna has them, Cigna has them, multiple Blue Crosses, Anthem, Humana, just to name a few. And then don't forget, so many of these commercials also have Medicare Advantage plans that follow Medicare guidelines. So an auditor has to be aware that there are some differences there from the commercial end to the Medicare Advantage plan side. Then let's talk about 95 and 1997 E&M score sheets, right? We're well into 2021. And although there are brand new 2021 guidelines for office and outpatient services that are available through the APC and NAMUS, and of course some of your MACs will now be publishing them on their websites to help you. We can't necessarily throw away our 95 and 97 E&M score sheets, right? Because those are still applicable to the inpatient services or home health side of things. So we have to hold on to it. But as we know, January 2021, as I just said, office and outpatient services are new, brand new. So APC already has those types of score sheets available. NAMUS has the E&M for 2021 score sheets available, and your MACs will start publishing them to help you as well. And then don't forget, most hospital systems, those internal teams will start developing score sheets as well to help you in 2021. An auditor will also have access to a great medical dictionary to stay up to date on terminology so they don't get confused on new terms and technologies and things that are happening. There's also CPT Assistant, very helpful, I find, to explain services in greater detail. And then there's also the American Hospital Association's Coding Clinic, which I find so necessary in explaining more details for our ICD-10-CM or diagnosis code structures and examples of when to use them. And then I love to look at the OIG work plan. That's one of my go-to tools. I'm looking at them all the time because the OIG for several years now, I believe 3, has changed how their work plans are structured to a monthly basis. So they're alerting us all in the public as to what they are working on. What do they identify as a red flag? So I find the OIG work plan to be very helpful and may help practice it. And then there's also the internal organization. So your hospitals may develop through their legal teams their own policies and manuals. And so an auditor needs to be aware that there may be some conflict there with the internal policy versus the federal regulations with Medicare, Medicaid, or the commercial policies as well. So it's good to be mindful. Then there's the medical society websites. So helpful in what they publish. Also a good tool to have. A CPMA may also be requesting your fee schedules. They want to help ensure that you're getting paid correctly, so you're not being under reimbursed. So they might ask for your fee schedule. And along that line, they may ask for your payer contract to see what's going on. If you're in network, out of network, what's happening. And then, of course, all of the websites. CMS has great fact sheets, especially in this time of COVID-19. It's still here. They have really upped their game in keeping us up to date with multiple fact sheets on almost a weekly basis now since March. And then, of course, there's the FDA website. Again, pivotal, so useful during this time of COVID-19 with all of the changes we've been seeing in the antibody treatments, in the vaccines, in all sorts of drug recall, things like that. I find it to be very helpful for my providers. And then, of course, there's the Department of Justice, another great website, the DOJ. I find it useful because they publish a lot of their exclusions on there. They publish a lot of the civil enforcement things that are happening. So which doctor did what in a bad way. Very useful in terms of what types of specialties the DOJ is also looking at. And then, of course, as I said earlier, the OIG website. So let's move on to documentation deficiencies that lead to coding errors. And these are all things that I see time and time again. And it's already 2021. So inadvertent holes in documentation lead to increased provider queries. So if that documentation is not as thorough, is not as accurate for a certified coder to abstract from, they will ask their providers, they will query them to see if any more specificity can be gained. So, but if those holes are not filled in, right, if there's that query overload and the doctor's inboxes are just, brimming with question after question after question, the certified medical coders unfortunately abstract those codes, both procedure and diagnosis, with less than, and non-compliance in coding begins and starts that ugly path, that rabbit hole downwards of non-compliance. So both inpatient and outpatient clinical documentation needs to see improvement to prevent the voluminous post-payment audits that I see in the everyday work I do at the law firm, and overpayment demands that are based on the non-compliant coding. So it's critical and vital because the medical record, the clinical documentation, as I said earlier, is central. It's the hub for all coding. So we need to clean up clinical documentation. That needs to improve, and then we can improve the coding. All right, top trends in documentation and coding errors. And this has been going on, and I still see it. These are still facts. This is not old news, this is current news. So, chief complaints are missing, or chief complaint status follow-up. This is a big no-no. Chief complaints are always in the patient's own words. A patient, a regular patient, not a patient who works in healthcare, just a regular patient who knows nothing about medical terminology or anything, is never going to pick up the phone and say, I need a follow-up visit for my 2-month post-op fracture. No patient will speak like that, So it's important that from an auditing perspective, try and use quotation marks. It's okay if the patient is panicked and worried about the rash that they receive that's burning underneath their cast from their fracture that they received 2 months ago. So the patient instead will definitely call in about their worry and their panic about this burning, kind of broken rash that has come up underneath their cast. So try and be mindful of that, things like that, because the chief complaint is necessary. Incomplete assessments and SOAP notes. I still see that. How is a certified coder going to code anything if there's an incomplete assessment? So there's no true and valid diagnosis that's been captured in the assessment. What service are you trying to do that's incomplete? The coder cannot do their job if that section is incomplete. And unsigned, undated documentation. I see this all the time. You cannot be sending claims out if there's unsigned and undated documentation. That's a big red flag. So what happens on the payer side? Payer side, not on my side. I work for the physician, not for the payer. On the payer side, those auditors are incentivized. They're incentivized to find the problem. And the moment they see an unsigned, undated piece of documentation, they throw it away. They do not bother looking at the wonderful, bright, detailed documentation that you did do because it's no longer a valid service if it's unsigned and undated. All payers have that in their policies, every single one, from Medicare to Medicaid to all the commercials. Documentation must be signed and dated. So let me emphasize again, the auditors on the payer side throw it away. They won't even look at it, and they will want that money to be recouped. And then late signatures, late dated documentation. I see that all the time as well. And there's no attestations to go along with it. That's also a big problem. Payers, you have to look deeply in their policies, but in general, what I advise to my physicians is 72 hours. You have a 72-hour window, and that's it. Final. Things need to be signed and dated within 72 hours. I always recommend you should have some sort of policy for that. You need to find a good workaround. How are you going to make that happen? Do you need a nurse who's going to, follow that, track that, help you out? How do you improve on your signature capture process? And then there's chicken scratch, illegibility. That's a problem. Now, for me, on the physician side, I always inquire, what does that mean? I read that as a mixed message. It could be read this way. Can we clarify it? But again, like I keep saying, on the payer side, those auditors don't care. If they can't read it, it won't be qualified. They'll throw the rest of it away. So I understand we obviously have to use paper for lots of things, for our orders, etc. But we need to make sure things are legible to an auditor so it can qualify and be scored appropriately and not just thrown out. And then continued top trends in documentation and coding errors. I still see orders that are missing. So when you have a lab, you have to have an order for that. When you're ordering a back brace on a patient, you have to have an order for your DME POS types of products like your orthotic braces. You have to have an order. And then again, that orthotic brace has to have a proof of delivery. Those are missing. So in a post-payment audit situation, they're asking you for all complete medical records and documentation. So if you don't have, at the time of the service, these orders on file, these proofs of delivery on file, unfortunately, in the post-audit situation, post-payment audit situation, when you go ahead and try and submit information to them that they're demanding, they will find those holes and say there's no proof of delivery, there's no order, we want that money couped, because those two things are a must in terms of keeping those money. And then the trends just keep on continuing. Upcoding. Let's talk about what upcoding is. The lack of accuracy in your E&M leveling. This has been going on forever. Hopefully we'll see some improvement now with the changes made in 2021 for office and outpatient. I don't know, it's too soon to tell, but upcoding, let's just talk about it. Let's just pretend we're talking about a Dr. Smith. And Dr. Smith has decided all of his patients that walk in his door, he is going to code everybody at a level 4 established visit. So he decided everybody gets a 99214. But how can every patient deserve that, right? That high level of service. The documentation has to meet the criteria to warrant a level 4 service. So the same is involved, the opposite, right? Down coding. Dr. Jones, you know, I worked with Dr. Jones and he misunderstood and thought I said, you know, be safe and down code. I did not say that, but he took the information to be, I'm going to down code. I'm not going to be on the OIG hit list this year. I'm just going to choose 99212 for everybody, right? So again, there's a lack of accuracy in E&M leveling. We need to make sure that we're capturing the severity of our patients' diagnoses. So we should be seeing multiple types of patient in a day, which means I would want to see multiple types of E&M services in a day. I would want to see a mix of the 99212s, the 99213s, and yes, you might have a multiple chronic condition patient that you're working up. So you might need that level 4, 99214 once in a while. But of course, your CPMA will help you understand if you are that outlier like Dr. Smith. He may very well see a lot of multiple chronic conditions, sick patients in his rural area because there's simply no other doctor like him in town. So yes, he fits. He's an outlier, of course, but he does see all of those sick patients because there's nobody else like him within a 150-mile radius. So in that case, I will fight for Dr. Smith every time because his documentation does support a level 4. Anyway, I digress. All right, unbundling is also a big one. So what unbundling means is you're disregarding coding edits. So let's talk about a surgical procedure. Say we're doing a laparoscopic cholecystectomy, right? We're trying to get that gallbladder out. But before you get to the gallbladder, the surgeon is looking at adhesions. Generally, there are a bunch of adhesions when you make that first cut. So how do you get to the gallbladder? You've got to get through those adhesions. Well, you've got to get through those adhesions. So when you perform that, it's a procedure called the lysis of adhesions. It's actually bundled into the laparoscopic cholecystectomy. Most surgeries, in fact, are bundled with that big procedure. But you're trying to capture that code also. You're trying to get the double dip payment. So you want to get paid for the lysis of adhesions as well as the lap chole. You can't do that. There's an edit at play, and a CPMA will help you understand that there's an edit there. So you can't apply a modifier to strip those two codes apart. But I still see it all the time. That's called unbundling. Then there's also modifier abuses that still go on with our modifiers 25 and 59. Those are the big ones. There's also modifier misunderstandings with so many others. Like, let me give you an example. For 2020, there was a brand new modifier on the OIG hit list. So if there's any co-surgeons out there that are listening to this webinar, there is modifier 62 that's now being looked at closely by the OIG. Then there's also when you capture codes only from the operative report header, I think you're missing a lot of opportunities, like especially in our cardiology services, our neurology services, you're missing a lot that you could capture if you're only coding from the operative report header. Then flip it over to the inpatient side. There's something that you call overbilling. And so what that means is you're trying to make the patient sicker by capturing a higher level of a diagnosis that's not actually accurate to increase your DRGs, to increase that revenue optimization market. The OIG in 2020 has had a lot of audit reports come out on this very thing, especially in, let's say, our diagnosis codes for severe malnutrition or marasmus. Now, last time I checked, America is not a third world country. We don't have those levels of starvation that qualify for marasmus as an ICD-10 code. So we have to be very mindful of how we capture codes. Then there's also our vendors, consulting companies, new technology companies that don't have certified coders on their teams. They absolutely do not. But they go around peddling their services and new technologies to offices or hospitals, saying, oh, this is the code you should use, this is the CPT code, or this is the HCPCS code, and this is how much money those codes pay. But guess what? I've seen this. These codes already exist for other services. They don't exist for this new technology. This new technology is brand new. There is no CPT code. So unfortunately, there's been a lot of services like this that I've seen, and they, of course, are in the surgical section of the CPT book. And of course, those garner a lot of RVUs, a lot of reimbursement. So those are no-nos. So I highly recommend that a CPMA get involved in situations like that, get your legal team involved in situations like that when you are considering a new technology or a new service line. Then of course there's our EMRs and our EHRs and all of the endless copy and paste that I see, the copy and forward abuses. And without any type of editing, it's simply a copy and paste, a lift from a previous date of service, a lift from something earlier that just keeps carrying forward again and again and again. And so what that does is that promotes this lack of individuality from record to record in patient. And that's not an honest and truthful patient record. Now, my biggest thing for 2021, I'm going to go around telling this to everybody. I really do believe that analyzing your own data is critical. Critical. So whether you have your own in-house CPMA or you retain an external CPMA, analyzing your own data is best practice. You shouldn't be afraid of it. It shows compliance. It shows that you want to be proactively compliant. It reflects your practice's overall performance. It sets up your baseline of your performance. You want to be at 95%. That's what OIG demands. 95% accuracy is your goal. So track and trend for yourself. Identify your strengths and weaknesses. Don't be shy. Turn those weaknesses into strength. You can only do that by identifying them. So identify the types of service locations. So when you want to track and trend for yourself, you want to think about where are you located? Are you just at your office, your place of service 11, or do you also have an office in the outpatient section of the hospital, place of service 22? So identify what service locations you'd like to audit. Then talk about how many providers would you like to audit? Just that Dr. Smith with all of his high level 4, 99214 E&Ms, or do you want to do all 3 of your NDs? Identify the service types. Do you want to do just all of your new patient visits? Or do you want to do all of Dr. Jones's lab coles, like I talked about earlier, because he was doing lysis of adhesions at the same time? Identify the time frame or the date span. Do you want to just look at the quarter, or do you need the whole year? Identify what payers. Now, I recommend auditing your entire payer mix at some point. I think that's very beneficial because, as I said earlier, everybody has a different policy and things change all the time. Identify a sample size. I recommend 10 to 20 charts per provider if it's a new audit, like if it's a new provider that wants to do this. Then, as I stated previously, who gets audited, right? It may be determined by the approach, like is it a proactive baseline audit where you want to get things done right the first time? Or, oops, you didn't take any of that advice and you've just been going all these years, and whoopsie daisy, you got the data mining letter in the mail. You got a cert letter. You don't want that to ever happen, but the data miners love to look at data. That's what they do best. They look at data. The data mining exists. Beware and be aware of it at all times. This is why this is my biggest soapbox for 2021. Start taking your data back and look at it for yourself first before the data miners get a hold of it. And what that means is the data miners are looking at that high volume of mistakes, right? High volume of level 4s, or those endless, marasmus, severe malnutrition types of ICD-10 codes. That's what the data miners look for, high volumes. So I think it's important and imperative to create an auditing policy within your compliance programs. Who's going to be on that auditing team? Who are your best players? And then implement that auditing policy and maintain it. Now, each organization is unique, so those internal audits are going to vary. Now, the methodology would ideally be standardized, ideally, but there are proven difficulties doing that based on the unique nuances to each practice. Now, as we know, teaching university facilities should have much more volume and more frequent audits conducted due to the vast complexity of cases and vast range of services and the multiple provider types that they have. Now, auditors that work for the provider, like myself, and not the payer, recognize that facilities have their own internal policies, like I said earlier. They have their own internal policies and guidelines and manuals that will differ from one another to the next, right? But it's important to understand, review, analyze those manuals in juxtaposition with the federal guidelines and the commercial payer guidelines, et cetera, to see what we're working with. Now, you should also be aware that internal pre-bill audits take more focus and dedication to the potential negative impacts of the revenue cycle. So recognize those internal pre-bill audits require no rebilling, and that your education will be immediate. But then on the flip side of that coin, when we have our internal post-bill audits, that may require rebilling by correcting those claims and sending them out, but there's a delay in your education because the importance then is on just correcting those claims and sending it out the door. Those internal post-bill audits require education from your team. Who on your auditing team? Who are your best players that understand all of your payers in your payer mix, right? And they all have timely filing requirements for corrected claims. So somebody should be there who understands that there's a 60-day timely filing requirement for somebody, or 90 for the other, or 180 for somebody else. Now, the types of audits. There are those baseline audits that I love. Those are those proactive ones when you want to do compliance right the first time. Then my least favorite of audit types are the prepayment audits. I don't like providers ever receiving a prepayment audit because your money is on hold. You're not getting paid, and your documentation needs to be perfect because you're sending that documentation out with the coordinating CMS 1500 or UB04 claim, right? So documentation goes out the door with those claim forms. So everything needs to be just right before you can start getting paid. I don't like prepayment audits. Also bad are the retrospective post-payment audits. Now, those are the ones I work with a lot. That's when the provider, the practice, the physician has received payment already. They got paid for all those services, but something happened. The auditor on the payer side is looking closer and wants to audit post-payment. So they want to recoup those monies, and they want all of your documentation to be sent in so they can look with the payer lens. And like I said, they're incentivized. Then there's also risk adjustment audits. So risk adjustment audits are for our ICD-10 CM diagnosis codes only. Those are for our Medicare Advantage plan. That's to determine the types of patients they have, what types of severe illnesses they have, which then inform the payer, the Medicare Advantage plans, of how much risk they will be taking on. Then there's, of course, the educational audits. I do like these. The attorneys that I work for don't like them, but I do like these educational audits, targeted probe and educate audits, because CMS does provide education. They do provide you access to talking to somebody at Medicare at your MAC. Your MAC will provide you with PowerPoint presentations and educational sessions on the phone to improve. But however, like the attorneys that I work for, this is still CMS, right? This is still CMS. So there are red flags, bells and whistles, hoops you have to jump through in terms of sending in things in a timely fashion. And if you miss those deadlines, you are penalized. So it's still CMS. So it's important that you try and get an attorney involved for any type of audit that you receive from a payer, because there are always hoops, bells and whistles, and things you have to jump through. Otherwise, you are penalized. So it's best to get someone on your side who knows what they're doing. But all of these types of audits will definitely have findings and outcomes of the audits after they're completed. So that's always good to have those educational findings. Now, the steps in any one of these audits is identical. So you're going to want to understand what is the scope, what's being looked at here, and then what's the sample that they're using, or what sample do you want to use when you're looking at a baseline audit. And then a CPMA will always get those materials, right? Just like the auditor on the payer side, they're going to get those materials, the documentation, the coordinating claims. If this is me doing the internal audit, I always ask for everything. I want those EOBs, I want those initial demographics, I want the patient consents, everything. What other tools and resources may be required? And then you're always going to be developing findings and a report. And then, of course, you're always going to want to deliver those results and communicate to the provider. Now, things are going to be site specific. So depending on if you choose an internal audit versus an external audit, it'll either be on-site versus off-site. I always develop a checklist of information needed in the audit. So like I said, my checklists are often 17, 18, 21 items long, depending on the type of provider and what they need. But we are in COVID-19, and COVID-19 has drastically changed the business of medicine workflow. So CPMAs need to adjust. We must, however, maintain HIPAA standards and require that BAA agreements as needed for the various parties involved. So we can't skip on that. We still need to meet HIPAA standards. Now, clear expectations. It's always vital to communicate clearly, right? What are the expectations on the timeline of our audit? Request missing information necessary to perform a comprehensive audit. So there are many times where I have to go back and ask for something more that I missed. It's important to remember each practice is unique. So you have to learn to gauge their preferences. Our providers are busy people. They're working, seeing patients from 8 to 5. Is it better for me to email them at lunch? Do they prefer phone calls or texts? Are they available on the weekends? It's important to learn to gauge what they prefer and always provide them with status updates during the audit process. And most importantly, help them understand that you're not the bad guy. Take out that fear factor of that ugly word audit. Audit, I know, it's still an ugly, bad word, audit. You think it's bad, but really CPMAs are there to help providers. So you want to instill confidence in the practice that this is a good thing. So I always develop my findings consistently throughout an audit, which means you should be creating spreadsheets simultaneously as you review those records with applicable data cells from the CMS 1500 claim form or the UBO for claim forms. Create columns of analyses that identify your deficiencies that you see, as well as all of the great things the provider is doing. You can create bar graphs or charts to quantify your findings, and always develop a written report that summarizes all of those deficiencies and highlights all of their good things as well. Make sure you let them know that next steps may include corrective actions that reflect compliance. And then communicate findings to the provider or the key practice players. Are there multiple providers you must speak to, an office manager? No. Additional education and training may be required. That's okay. A CAP, a corrective action plan, may need to be implemented. And then always provide recommendations based on those deficiencies identified. Do we need to do some follow-up continued smaller audits? And in what time frame? And again, remember when you speak to our providers, watch your tone because you're on their side. You are a provider champion. So you should always speak to them clearly and let them know that you're on their side. And then remind the provider and the entire practice to document all of that continued education that they take, their training sessions that they attended post-audit, because this reflects favorably towards maintaining compliance. And then I always like to send follow-up emails to get their status updates on what changes they see, what improvements have been made since you last audited them. So some of my final thoughts. I really think, I hope I made this abundantly clear in this presentation, that it's important for our provider and a practice to conduct self-audits. Retaining the experience of a certified professional medical auditor, a CPMA, can give you the peace of mind that you're placing compliance front and center at your practice. You can continue seeing patients, do all of the good work that you were trained for, but your CPMA can help you remain compliant on the business side of it. CPMAs are trained professionals who understand that clinical documentation, that physician claims data, they understand that administrative data requirements, they understand all the codes, the many, many codes. CPMAs strive to maintain quality assurance, mitigate coding and documentation risks, and facilitate compliance with all regulations from federal to state to payor. Now, in this current climate where fraud, waste, and abuse numbers have reached the billions of dollars mark as of 2020, I think it's truly imperative to get ahead and to stay ahead by beginning proactive compliance within your practice. Start auditing yourself on the road to your own success. So I give you my list of resources there. Hopefully that will prove very helpful and beneficial for you. Don't forget to look at your own Macs. I use the Palmetto GBA here, but they all have their own website, so make them your friend. So I think that's all I had in this presentation, and hopefully some people have some questions.
Okay, thank you so much, Sonal. That was a wonderful presentation on auditing, and we do have a few questions. So the first one is, why do you think physicians and practices are not conducting self-audits? What are your thoughts on that?
Oh my goodness, wow, that's a great question. Why haven't they been doing it? Yeah, so there's probably a lot of different answers. I'm sure a lot of people have a different opinion. But I think, in my opinion, I think there's just not enough attention that's being spent on the data, the actual data that physicians create. I truly believe that the data speaks volumes, and the data is the physicians, right? They are the ones who send those claims out. Payers use that data against them time and time again when it comes to the volumes of service or diagnosis errors, like I talked about, the upcoding, like I said, the overbilling, like I said. I believe that practices must begin taking action on their own data without any type of fear, because doing things right the first time before claims are sent out to avoid payer scrutiny later, to avoid recoupments, is the best thing to do.
Okay, great. Now, we have another question on this. Do you think healthcare practices should have someone in charge of changes and policy updates, et cetera, things like that?
Oh, wow. Yeah, that's another insightful question. I think I touched on that earlier. And I know I just gave another presentation recently where I told the audience, I believe it's ideal that you should appoint, your strongest people who have these types of skills. Appoint a Medicare person, appoint a commercials person. Let your internal pros at that type of thing shine. Let their research and policy, let those types of research and policy, gurus on your team do what they do best, and then they can distribute it and disseminate it to everybody. Yeah, that's a great question.
So I mean, ideally, I guess you would have um, separate hires for that, but would you say you would designate, perhaps if you didn't have separate hires, would you designate certain people within your organization who perhaps you've noticed have seem to be leaning in that direction, and then you would perhaps have them train more in that direction if you if you didn't have separate hires for that?
Right, absolutely. That's also a great follow-up. Yes. So in this time of COVID, absolutely, you might not get those separate hires, but there are definitely people on your team, who you've been watching closely over the years, and they have a finesse for research. They have a finesse for those MACs, and they understand how to navigate the complexities of the Medicare website, and they know how to look for those LCDs. So absolutely find those people and promote them into those types of roles, because the more you instill confidence in your people, they will undoubtedly help you remain compliant. So yeah, absolutely, you should definitely be promoting people, stretching them in those particular areas of helping you to research policies and guidelines, either on the government side or on the commercial side. Like if you have a pro who knows how to do the Aetna website very well for their clinical policy bulletins, do it. Just, give them that extra responsibility, and it will only help your practice grow.
Okay, great. Okay, so there's another question about some of the things that you have. So somebody says that you have like a lot of tools for helping. Did you pay for all of these yourself, or should you expect should one expect their employer or physician to help them out, or should they do this themselves, or what do you recommend, or how do you see this going?
Oh, wow. Yeah. Okay. So those
That's
are
a
a
good
lot of,
question.
yes, that's a great question. Yes, I do have a lot of tools. I do, but I really do believe, I don't think I'm alone in this. I have a passion for what I do. I love my job. I love helping providers. And so, yeah, to maintain what I do as an auditor, as a compliance specialist, I do believe you have to have all of these tools. You cannot be working off of coding books from 2015 in 2021. You just cannot do that. So yes, I do. I pay for everything myself. But yes, I have to strategically ask my employers over the years to reimburse me, to help support me, and they always do. So, I mean, you have to have transparency with who you work for. I think, like I said, communication throughout this presentation is key. You're communicating with your providers, but whoever you work for, whether it's like myself at the law firm or you do work for the provider, you have to have that open communication with them that you are doing this to support them. You want them to win. You want to be on their winning team, right? So it's imperative that you ask for that reimbursement, but do it strategically. Like don't buy these coding books at the peak of their price tag. You do strategic shopping, just like we do sales shopping for everything else. You have to wait for the deal, but then you go ahead and get those coding books. Just like if you want to attend, well, now it's virtual, but just like if you want to attend a conference, you have to ask for that permission, write up a proposal for them, how it's going to benefit them, so then they can help support you and reimburse you in attending that conference, whether it's on site like the old days or virtual like the current times that we live in. But yes, absolutely, it's imperative that you have all of these tools, that you're aware of all of these tools, if you want to help support the providers in compliance. Yeah.
Yeah, I think that's great advice because, of course, we all are striving to do our best, and that we want to be the best that we can be, because we want our companies and our providers and whatnot to be the best that they can be as well. And so I think that's worth emphasizing as well. And we need the best tools that we can possibly have to make that happen. So
Absolutely.
that's very good advice. Yeah. Okay, well, I wanted to thank you so much for being here. Did you have any final thoughts for us, or anything else that you might have thought of during the presentation?
Final thoughts is just please start auditing yourselves. I'm going to say that again. Just start auditing yourselves. Don't be afraid of any weaknesses that you think you have, because you can easily turn that around and just improve and do better. So the auditors on the payer side don't come back in a year or two demanding their post-payment recoupment things. So yeah, final words, please start auditing yourselves. Start looking. Yeah.
Yeah, start now, right?
Start now. It's not too late. Start now.
Okay. All right. Well, thank you again so much for being here. Attendees, make sure that you get in contact with Sonal, check out her podcast and check out her her other resources. And thank you again, Sonal, for being here. And attendees, thank you for joining us as well. And please use the contact on the screen for any other additional questions that you might have, or if you think of them later, send us questions and we'll forward them on. Please remember your PAYCOM and your PMI CEU certificate will be emailed to you from within 2 days following the broadcast. There's no need to request it. You can register for future webinars or request a demo of our compliance solution on our website at firsthcc.com or call us at 888-543-4778. And thank you for joining us.